Major depression is the leading cause of disability worldwide, affecting over 300 million people. Yet the average time from onset to first treatment is 11 years, and roughly half of people with depression never receive any treatment. Depression is not sadness. It is a biological and psychological condition that physically changes the brain, impairs functioning across all life domains, and carries a significant mortality risk from suicide. Understanding it is understanding one of the most important challenges in global health. Major depressive disorder is diagnosed when 5 or more of a specified set of symptoms are present for at least 2 consecutive weeks, causing significant impairment in functioning. The 2 core symptoms are depressed mood, feeling sad, empty, or hopeless most of the day, and anhedonia, loss of interest or pleasure in almost all activities. Additional symptoms include sleep disturbance, insomnia or hypersomnia, appetite and weight changes, psychomotor agitation or retardation, fatigue, feelings of worthlessness or excessive guilt, concentration difficulties, and recurrent thoughts of death or suicide. Persistent depressive disorder, previously called dysthymia, involves a chronically depressed mood that persists for at least 2 years in adults, with at least 2 additional depressive symptoms. The symptoms are typically less severe than major depressive disorder, but are more persistent, creating a background of low mood, low energy, and diminished well-being that the person may describe as their normal personality rather than a disorder. People with persistent depressive disorder often also experience episodes of major depression, a condition called double depression, making their overall burden of depressive illness severe. Bipolar I disorder is defined by the occurrence of at least one full manic episode, a period of elevated or irritable mood lasting at least 7 days that is present most of the day, nearly every day, with significant functional impairment. During manic episodes, individuals typically show grandiosity, decreased need for sleep without fatigue, pressured speech, racing thoughts, distractibility, increased goal-directed activity, and dangerous risk-taking. Major depressive episodes typically also occur, though they are not required for the diagnosis. Bipolar I has a strong genetic component, with heritability estimates above 60%. Bipolar II disorder involves hypomanic rather than full manic episodes. Mood elevation that is less severe, does not cause marked functional impairment, and does not require hospitalization. Hypomanic episodes are often experienced as increased productivity, creativity, and sociability, periods when the person functions well or even better than usual. The major depressive episodes in bipolar II are typically severe and are the primary source of disability. Bipolar II is frequently misdiagnosed as unipolar depression because the hypomanic episodes are often not recognized as symptoms, leading to inappropriate treatment with antidepressants alone. Cyclothymia involves chronic, low-grade mood cycling between hypomanic symptoms and mild depressive symptoms persisting for at least 2 years in adults, without meeting full criteria for either manic or major depressive episodes. Cyclothymia is often experienced by those who have it as a personality characteristic rather than a disorder, described as being emotionally sensitive, up and down, or volatile, and is frequently unrecognized. Cyclothymia carries elevated risk of progression to bipolar I or II disorder and is associated with significant interpersonal and occupational instability. The monoamine hypothesis of depression proposes that depression results from reduced availability or activity of monoamine neurotransmitters, serotonin, norepinephrine, and dopamine, at brain synapses. The hypothesis was supported by the observation that drugs that deplete monoamines can induce depression, while drugs that increase monoamine availability, tricyclic antidepressants, MAOIs, and SSRIs, are antidepressant. However, the hypothesis is incomplete. SSRIs increase serotonin availability within hours, but take 2 to 4 weeks to produce antidepressant effects, suggesting that monoamine changes trigger downstream neuroplastic changes that are the actual mechanism. The neuroplasticity or neurogenesis hypothesis of depression proposes that chronic stress suppresses hippocampal neurogenesis and synaptic plasticity, producing the cognitive impairments, memory difficulties, and stress hyperreactivity of depression. Structural neuroimaging consistently shows hippocampal volume reductions in people with chronic depression. Antidepressants, chronic exercise, and ECT all promote hippocampal neurogenesis, and this neurogenic effect may underlie their therapeutic benefits. The 2 to 4 week lag before antidepressants work is consistent with the time required for new neurons to functionally integrate into hippocampal circuits. Aaron Beck's cognitive model proposes that depression is maintained by characteristic patterns of distorted thinking. Negative core schemas, deep beliefs about the self, world, and future formed by early adverse experiences, generate automatic negative thoughts in response to everyday events. These thoughts, biased toward negative interpretations, maintain and intensify depressed mood. The cognitive triad captures the content. I am worthless, the world is unfair, and the future is hopeless. Cognitive behavioral therapy for depression targets these thoughts and schemas, producing durable improvements with relapse rates lower than medication alone. Mood disorders are among the most common, most disabling, and most treatable conditions in psychiatry. The neuroscience of depression has moved far beyond simple monoamine deficiency models toward understanding the complex interactions of stress, neuroplasticity, genetics, and cognition that produce and maintain these conditions. Evidence-based treatment, antidepressants, CBT, and their combination, is highly effective, making the 11-year treatment gap a tragedy of access rather than a failure of knowledge.